Firstly, thank you to the Leg Club for inviting me to speak today and for giving me such a nice title as well. Normally Ellie thinks of something really ghastly for me, so don't look like that. Thanks for this one, Ellie. Dealing with everyday management of the lower limb and its impact on quality of life is actually quite close to my heart, because I think as nurses, I cover community nursing, or a team of nurses who work in the community. Trust me, I rarely foray out there myself because I don't want to traumatise the client group too greatly. They have it tough and they're very time pressured, and I think sometimes that stops people taking that critical step back that they need to review what's actually going on with the patient. So hopefully we'll cover part of that and why it's so important and how it impacts on the patient. Ooh. Quality of life. As professionals, as clinicians, we tend to have really quite clinical indicators of what we think quality of life is about. If you talk to your patient, they actually have quite different ideas of quality of life, and some of them might not quite match, whereas some of them will overlap. The biggest is always pain. And there's a wonderful quote by a guy, I think it was called McCaffrey, who said, "Pain is what the patient says it is." Some of you will have patients who will appear to be on multiple pain analgesia. They will appear to have climbed the analgesia ladder. Well, surely it doesn't hurt. You're on all that pain relief. I think they just like the tablets, No, perhaps we need to carry on referring them on. Perhaps we need them to go to a pain clinic. Perhaps what we're giving them isn't actually working and we're not listening to what our patient's actually saying to us. Perhaps the pain is because we've now got a bit of claudication. Pain is what the patient says it is. Sleep. It all matches for me with pain. I am like a bear with a sore head if I haven't had any sleep. I've had an hour's sleep from last night. I feel I'm doing remarkably well, really. If that went on, though, I would be a nightmare to work with. Hannah, if you just like to shut up and not tell everyone I'm a nightmare to work with anyway, that would be quite good, love. But sleep is absolutely intrinsic to our mental well-being. It's an essential part of our quality of life. Life's autonomy. I appreciate the fact that not everyone is a control freak. Okay, I probably am, to be fair. Okay, I can't imagine anything worse than having a leg ulcer and being at the beck and call and dictate of somebody else and not having that control over my own life. And that can be something really, really simple like, do you know what? I'd like to have a shower every day, but I've got these bandages on and, there are products out there on the market that can help with that, but nobody's actually told me. Because it's not occurred to us that that's part of our quality of life that's being seriously affected. We can only have a shower once a week when the nurse comes to change our bandages. That's not great. And it's a small thing that makes a huge difference to somebody. Waiting for visits. It's a morning call. We'll talk more about that later. But being able to do what you want to do when you want to do it. Go down to the shop without your bandage trailing behind you because somebody's not replaced it and your edema's gone down. Little things make big differences to patient quality of life. The psychological, I won't drill on about this because I can probably talk for England on it, but depression is huge, and it's not just depression. You think about the life cycle of a leg ulcer and it's a roller coaster for your patient. It's an emotional roller coaster. 1 minute that leg ulcer seems to be doing really quite well and everybody's really pleased, and then all of a sudden something will happen. Whether it's within your power, the patient's power, whatever, something changes and it starts to go down. And that little light that was at the end of the tunnel, somebody's just knocked it out. It's a roller coaster for that patient, and we need to be able to support them through that. The only way we can support them through that, picking up on what Jackie was saying, is understanding the processes ourselves and understanding our patients so that we can actually talk them through what's happening. And more importantly, not only do we have plan A, but we've got plan B and C as well. Consistency. Again, this is something that I'm not going to dwell on. Jackie touched on it and I'll talk more. But in a number of investigations I've done for my own trust, one of the things that comes up time and time again is consistency. And mobility, last but definitely not least. Many of us take for granted our own mobility, the fact that we can get up, do what we like, make fools of ourselves on the dance floor, whatever. For some of our patients, having a leg ulcer, whether it's the pain associated with the leg ulcer or it's fluid, bandages, can't get our shoes on because somebody's put us in 4-layer, can affect our mobility. That will knock on to our psychological effects. That will knock on to our life autonomy. It all goes together. As nurses, little changes that we can make by understanding what will affect our patients' quality of life can make a huge difference. So clinicians, you'll be pleased to say that the evidence shows that we all think pain as well. So it's good that that's up there at the top. But we then start thinking about odour and exudate, very clinical things. And yes, they all impact for the patient, especially things like odour and exudate, because they can affect our mobility, our getting out, our psychological aspects. But as clinicians, we don't tend to drill it any further down than that. So really, what we need to do is focus on how do we support our patients' quality of life by the way we manage it on a day-to-day basis. So the first thing to ask is your patient on the right pathway? Many of you will be familiar with the pathways associated with the AQP standards. These are the pathways from my own trust. We have simple, complex and mixed. A simple leg ulcer should heal within 18 weeks, a complex within 24 weeks, unless something happens and they hit the mixed pathway. One of the team has recently completed an audit to look at healing rates because our CCGs want us to be able to demonstrate that we're delivering what we say we're going to deliver, and actually our simple pathway healing rates, our overall healing rates are 83% of what they should be. So within that 12-week or 24-week time frame, which isn't bad when you think you'll have non-concordance and things like that. So we're getting there. We're quite pleased with that. So, is your patient on the right pathway? Have you given them the right set of expectations? You need to have the confidence to explain to your patient what is actually wrong with them. You need to have that understanding, and as Jackie said, put it in the right terminology so that they understand, this is why I've got a problem, this is what will help it, this is what I can do, this is what my nurse is going to do for me. Ankle brachial pressure index, it's the standard, isn't it, for when we're looking after leg ulcers. Somebody has a leg ulcer, we do an ABPI to determine what pathway we think they need to go down. Many of you will have been in Trudy's session yesterday and discovered that actually the ABPI is a mine of pits waiting for us to drop into. Now I'm lucky. I have my own Doppler, I have 2 cuffs and I have 2 probes. But you all have the correct cuffs and probes when you go to see your patient. If you're putting a cuff that is too small on a large limb, you are going to get a false high. If you get those false highs, what can that mean for your patient? Well, basically it can mean that they're not on the right pathway, because they might actually have some arterial disease that you're not picking up because you've got the wrong cuff on and you're getting a false high. And that will affect how they heal and their potential problems further down the line. Have we got the right probe? It horrified me to discover that some of our own hub clinics, where their nurses are expected to do these things, only had one type of probe. How on earth can you run a hub clinic with an 8 megahertz probe? You need both. So think about your own areas. Do you have both probes? Are you all scrambling over one probe between 7? You can't do the job and you can't do justice to your patients and ensure they're on the right pathway and therefore manage their leg appropriately day in, day out if you don't have the right equipment. Pulse sounds. I did have some nice little soundbite things, but for some reason I was having an IT nightmare and couldn't copy and paste them, so I'm really, really sorry. But if you Google pulse sounds, so tri, bi, and monophasic, you can actually Google them and the sound files will come up for you. And it's worth a listen because personally I always use the headphones because I hear better with them on and I'm not distracted when I'm doing it. I find try and buy quite difficult. Does everybody else find that? Sometimes I'm really listening hard to get the difference. You're all looking at me really blankly. Am I the only idiot who finds that quite difficult? Oh dear. Monophasic's easy, isn't it? Boom, boom, boom. And you're immediately thinking, ooh, your arteries aren't sounding good. Vascular. Then you've got your tri. Boop, boop, boom, boop, boop, boom, boop, boop, boom. Your bi. Boop, boom, boop, boom. Sometimes it's not always that easy to differentiate them, okay? But it is important, practice it, listen to your pulse sounds. And I learnt something yesterday, and I'm sure all of you did in Trudy's session, about the pressure difference between the DP and the PTP. If it's 15 millimetres of mercury, there's disease present. I didn't know that. I'm glad you're going. Makes me feel a lot better. So yeah, there's always things to learn. But again, it's getting it right for the patient. So know your sounds. Symptoms, not figures. Now, what I mean by that is sometimes as nurses, and I know this from, again, sadly, an investigation I did, whereby the ABPI was 1.1 and 1.2. So the patient went into compression. Nothing wrong with that, you think. Except when you read the holistic assessment part of that leg ulcer assessment, you get to the bit where the patient described claudication. So that patient should have been referred, shouldn't they? Back to the GP, off to vascular, let's have a look. No, they focused on those final figures and they put that patient in compression. 9 months later, that patient died, and just before she died, she was in tremendous pain with an ischemic limb. What quality of life did we offer her with our management of that limb? It should have been fairly simple. She died in real pain. And her family, who put in the complaint, what they were most concerned about was the fact that she was in so much pain. So it's not just that end figure, it's what is your patient telling you about their symptoms. And are they on the right referral pathway? How many of you seen legs like this? It's like a slab of meat, isn't it? It's like the top layer's gone. And it's actually stasis eczema that's really wet and out of control and needs a dermatology appointment. But the community nurses were managing that for months. Wrong pathway. Those legs dried up beautifully once she'd seen dermatology. And I must admit, I'm not always a fan because they start putting potassium permanganate on everything. And as tissue viability nurses, we run away screaming. But he actually used a steroid cream, dermal 500 lotion, and she's now in hosiery as maintenance to stop the leg breaking again. So it's the right referral pathway your patient needs to be on as well. And when I say right referral pathway, I also mean those patients that, let's face it, if they're on your books, they're concordant with their care, they don't have horrendous comorbidities, and they've still got a leg ulcer a year down the line, I'm sorry, they should be being referred to a specialist service with tissue viability nurses. What is going wrong? Why is this not working? Why is this patient not recovering? We need to take a step back, and my favourite word for my team, and I think they duck every time I say it, is you need to critically analyse what's happening. Stop throwing stuff at it. Step back, critically analyse what is going on with this patient. So appointment times. How many times is a patient booked in? 10:30 appointment. Something happens. The visit before goes completely wrong. You're there for ages. You're going to be late. How many, just in your brains, reflect, I don't mean to put anyone on the spot, but contact admin and say, can you ring Mrs. So-and-so and let them know I'm going to be an hour late? Or have we got our patients sitting waiting for us because they know the nurse is coming to do their bandages? But actually, that patient's got things to do. And if they know you're going to be an hour late, they perhaps could nip to the post office and be back for you. It's a simple thing that not everybody sadly does. Leg washing. Oh, I was horrified to discover that not everybody gets the legs washed. I'm also horrified that the NHS today, where I work, expects a community nurse to do a single leg in 15 minutes. I'd love to see our managers do that. You know, I could probably, like Jackie, just about get through the door, unpack my stuff, chat to my patient, get my kit out. Oh, it's 15 minutes gone. I'd be sacked because I couldn't keep up, because I'd want to do a quality job. Sadly, our nurses out there are under tremendous pressure, and leg washing appears to be one of the things that have gone. But how would we feel, you know, if the only time we got our leg washed was once a week when the nurse came and it wasn't done? Think about that hyperkeratosis building up. You know, it just takes us to wash it in a bit of a certain debridement pad possibly to get it off. Or if you're a picker, some people are pickers. I have to confess I'm not a picker, but some people are happily there taking it off. It will all improve things for your patient. Leg washing is not something we can miss. Our holistic assessment. Managers love to bandy that word around. Holistic assessment. I can't remember when it became sexy, but it's been around for a while. And there is something about that. And there's something about what is our patient's medical history. What's going to impact on healing? What do we know is going to impact on healing? Because again, it's about explaining to our patient, this is what's happening with you. This is what will delay healing for you, but this is how we're going to manage it. We're going to optimise your condition by doing this. This is how your wound looks. This is what we need to achieve with your wound. We need to have confidence and knowledge ourselves in order to impart it correctly to our patients, to give them the confidence in what's happening to us. There's nothing worse as a manager than hearing a patient say, the nurse didn't seem to know what she was doing. And we hear that. Named nurse or visit list. My background's hospitals. I was shocked to discover that community nursing in my area had gone away from named nurses. And it was a visit list. Imagine the patient, in the course of a year, could have 12, 13 different nurses visit them. Where is the continuity in that for the patient? The consistency I mentioned earlier that is so important to their quality of life. Where is the nurse with the knowledge of what is going on with that patient, who can recognise instantly that something isn't right? It's gone. Because if you've not got consistency, you don't have that. Fortunately, on the back of a complaint, it's always on the back of a complaint, isn't it? Or possibly a coroner's report. They all tend to blend after a while. We're going back to the named nurse concept in our community teams, and I can only applaud that because it will be so much better for our patients, and it will help manage their limb from a day-to-day basis and ensure we tick their quality of life boxes, not our quality of life boxes. So, there's lots of bandage systems out there, isn't there? It's choosing the right one for your patient, not the one that you happen to like best. So you can see you've got your 4-layer, you've got your 2-layer long stretch, you've got your wraps, you've got the ones now for the mixed etiology ulcers. We've got some badly applied bandaging. I particularly like the one centre bottom. Short stretch. People will say, oh, it slipped. No, actually, the patient had edema. It's done its job. It's reduced the edema. So yes, it's kind of slipped because of that. How many of you, though, with your patients who have edema with their leg ulcers, let the patient know this is likely to happen because the edema will be resolving. When this happens, ring SPA. We'll send someone out and we'll put it back on to adjust for the new circumference of your leg. Or are we Tuesday, Friday visits? Is it Tuesday, Friday, Monday, Thursday? Set. We're rigid in what we do. That's not patient focused, and it's not looking at what's best for our patients to give them the best quality of life they can get with a leg ulcer that's being managed. Hosiery. Do they want bandages? Do they want a wrap? Do they want a hosiery kit? What do our patients want? What suits them better? Personally, I'd rather have a hosiery kit any day over bandages that I can't get my shoes on with. But do we give our patients choices, or do we just go with what's on formulary in our cupboards? Aids to get compression hosiery on. I don't know how many of you have tried putting class 2 on, but it's not easy, is it? And then we've got European standard and British standard. Which do we give our patients? Do we give them the European standard that has a higher stiffness rate? Or do we give them the British standard that has less compression but might be easier to get on for our patient? Is there anywhere there that can help them? Do we need to order some of these aids for them? Do we think it right through? Or taking it back to what Jackie said earlier, are we looking at that 35% who concord with their hosiery? Could these be reasons why they don't? Because they don't really understand. A lot of them used to say hand wash only, which I think is a huge barrier for people using compression hosiery. Because in the modern world, we don't tend to hand wash, do we? These are Anita's particular bugbears when it comes to management of lower limb. So I'm just checking my watch so make sure I don't go over. Cellulitis. I would imagine most of you, like Lester, have a cellulitis pathway. And cellulitis will be graded, stages 1, 2 and 3, depending on your patient and depending on your patient's comorbidities. Too many times we are finding that our prescribers, so for us that's GPs, are not following the cellulitis pathway. So patients are receiving suboptimal treatment. You'll discover the patient with cellulitis, repeat episodes of cellulitis, who's been on 500 milligrams of Fluclox QDS for 5 weeks. Yeah? It's suboptimal. Should be a gram. It's no wonder they're not getting anywhere. But where are we in checking that our patient's on the right antibiotic? And if we discover they're not on the right antibiotic, challenging that prescription, having the confidence with our pathways to say, I think they're on the wrong antibiotic. Because not only that, but if they have comorbidities, they should be on additional antibiotic. Too often it's not happening. So cellulitis, one of my particular bugbears, because the pain that gives, people often come out of compression because of the increased pain with the cellulitis. Then sometimes people are reluctant to put them back in it because it's cellulitis. You're in a downward cycle then for your patient. The leg that you'd got under control, the edema you'd got under control is coming back. The exudate is coming out again. The wound's getting bigger. That emotional roller coaster for their life because we've got them on suboptimal treatment. Swabbing. It's never complete without talking swabbing. Some people are swab happy. I'm not quite sure why. They see a wound, look at it, well, that doesn't look nice, let's swab it. Why? What do you want to achieve? What do you want to get from it? Are you looking to confirm infection? I do hope not. Because to be honest, if it's a fairly large ulcer and you've taken one swab, you might as well, oh, I've just thought of a naughty term that I can't say, won't say it, Ellie, something to do with wind, because there's no point. Swabs are only useful if you want your patient or your patient needs antibiotics and you want to check that they're sensitive to that antibiotic. But the problem you've got is that a lot of ulcers, the problem isn't aerobic, it's anaerobic. Your swab's not going to pick that up. This is where, we need to have the confidence as nurses. A swab is not your diagnostic tool. Your brain and your clinical assessment of infection markers is your diagnostic tool. You all know what infection looks like. You all know what the clinical markers for infection are. You don't need a little swab to tell you it's infected. You don't need a little swab to say you've got a host reaction and therefore it needs to be treated. So think carefully with your swabs. Biofilms. Those of you who, like me, have been around for 100 years will remember that in around 2005-ish, the buzzword in wound care was matrix metalloprotease inhibitors. Yeah? Everybody remembers protease inhibitors, that was it. And suddenly, every dressing known to man was a protease inhibitor. Didn't matter that for years and years they'd been catalogued as something else. All of a sudden, they're a protease inhibitor. Really? Right, okay. Yes, MMPs are important. We know that. Yeah? The latest buzzword for the last few years is biofilm. Everybody's got a biofilm buster. Everybody's dressing bugs, biofilms, whatever. And that's not to say that they don't exist, because we know they do. We know there's very good evidence that in chronic wounds they exist. But again, it's how chronic is chronic. And I always say this to the reps who are trying to sell me their biofilm buster, and they're giving me this evidence. 86% of chronic wounds have a biofilm. Are you telling me the 7-week-old wound's got one? Because that's theoretically a chronic wound, isn't it? It's over 6 weeks old. I doubt it very much. Give me the wound at 10 months, yeah, probably. So don't be fooled, okay? Don't throw things at your wound. When your leg ulcer isn't doing what you want it to do, don't just throw the latest product at it. Step back, look at it, think, critically analyse what is happening, because by doing that, you are doing your patient the best service you can. And by doing that and getting the treatment right, you will improve their quality of life. But too many times, nurses just throw another dressing at it. Your new best friend should be microbiology. Microbiology are an extremely helpful department. Where you've got patients with recurrent infections of their leg ulcer that are not healing, that you don't appear to be going anywhere with, contact microbiology. They will have a swab history, so if your patient has been swabbed into submission, they will have all the results. They will have the antibiotic history for your patient. You can tell them what's going on. You can tell them what you can see. Remember, stick to the clinical markers of infection you've got. What is going on with that patient that is different, that's changed, that's made you where you are? And they will help guide you and will often today start them on this. So, to illustrate this point, this is a patient of mine. This patient had his leg ulcers for 13 years. I could not believe somebody could have their leg ulcers that long. He was referred to me by the practice nurse. He had no life, no quality of life at all. He was having suboptimal treatment in every single sense that you could imagine. The practice nurse would bandage him. By the time he got home, the bandages were leaking through. By the evening, his wife was changing them. He was seeing the practice nurse twice a week. In between, his wife was changing his bandages, not compressing, I hasten to add, 3 times a day. They couldn't go out, they couldn't go on holiday. It was just, and you sit there and you think, how have we got in this state? So again, you take a step back. That, I had no doubt at all, would be biofilm happy. So you take a step back and you think, okay, what do I want to achieve? Have I optimised my patient? Because that's a huge thing about it as well. So with this particular patient, we used the Debrisoft pad and we used Prontosan, and we put a different super absorber on that was a better quality, shall we say, than the one the practice were putting on. And the patient was very sceptical, shall we say. It worked. He hadn't had his bandages leak through by the next day. So he was very happy with that, and it meant we could start compressing. And this was fine, and then things sort of stopped and slowed. And I thought, hey, up. So the community nurse says, shall I swab it? No, don't bother. So we ring microbiology because we've got a pattern here. Microbiology advised, get him on linezolid. They wanted a 10-day course of linezolid for the man. They looked up all his history, all the antibiotics he's had, all the problems, bearing in mind this was a guy who was also on a low dose of penicillin V as maintenance. So, this is what we ended with. The last time I saw him. Sorry, that's not as clear as I would like it. Those photos were taken 3 months apart. That is called stepping back, looking at your patient, critically analysing what you've got, getting them on the right referral pathway, and improving their quality of life. I'm really pleased to tell you that patient is now healed. His quality of life has improved massively. So, as we've alluded to, lower limb management, leg ulcers, are a financial time bomb for the NHS. Nurses, I couldn't find a picture of tongs, so I'm afraid nurses are going at it hammer and nails. But actually, a lot of the time, they're ineffective because they're not standing back and looking at it, they're throwing products at it. What nurses need to do is put their thinking caps on. Take that step back. Work in partnership with all the different people, so you're patient, so that you know what they want. Different professionals, be it GPs, nurse specialists, dermatologists, vascular, whoever, work in those partnerships. Your patient might not do that at the end of it, because let's be frank, not many of them look like that. But what you might get is that, a patient with healed leg ulcers who's in hosiery and is living life to the full again. Thank you.